about the therapeutic uses and adverse effects of epinephrine. So I will be discussing the therapeutic uses of epinephrine using the mnemonics A, B, C, D and E. A stands for anaphylactic shock, B stands for bronchial asthma, C for cardiac resuscitation, D for delayed action of local anesthetic effect, E for epistaxis. Starting off with the therapeutic uses of adrenaline. Adrenaline is the drug of choice for the management of anaphylactic shock. Anaphylactic shock is a hypersensitivity reaction that involves the release of mediators from mast cells, basophils and recruited inflammatory cells. It is an acute, life-threatening condition that involves two or more systems. So these include mucocutaneous symptoms such as urticaria, rash, angioedema, flushing. Respiratory symptoms can occur such as upper respiratory symptoms, rhinorrhea, dysphagia, angioedema. Lower respiratory tract symptoms such as airway obstruction, bronchospasm and wheezing. Cardiovascular symptoms can manifest in the form of hypotension which can trigger arrhythmias. Neurologic symptoms can occur in the form of headache, dizziness, confusion and syncope. So what is the pharmacologic basis for the use of adrenaline in anaphylactic shock? Adrenaline, by acting through alpha-1 receptor stimulation, increases the peripheral vascular resistance in the blood vessels, thereby increasing the blood pressure and restoring the blood pressure to normal. By stimulating the beta-1 receptors of the heart, it increases the heart rate and cardiac output, thereby improving the cardiac performance of the heart. By stimulating the beta-2 receptors of the bronchial smooth muscles, it can dilate the airways. This helps in increased oxygen uptake and reduces respiratory distress. By stimulating the beta-2 receptors on the mast cell, it can decrease the release of mediators from the mast cell and thereby control inflammation in bronchial asthma. So adrenaline can be administered at a dose of 0.3 to 0.5 ml in a solution of 1:1000 and administered intramuscularly. So subcutaneous route is unreliable as there is hypovolemic shock and the absorption is delayed. Intravascular route can trigger the onset of arrhythmias. The next therapeutic use is bronchial asthma. Adrenaline can be used in the treatment of bronchial asthma because of the following reasons. Firstly, it increases the diameter of the airways. By stimulating the beta-2 receptors of the smooth muscles of the bronchial airways, it causes relaxation of the smooth muscles. And by stimulating the alpha-1 receptors of the blood vessels of the skin and mucosal membrane, it causes shrinkage of the mucosa and both together result in dilatation of the airways. So this helps in relieving respiratory distress and increases the oxygen uptake. Secondly, it also decreases the bronchial secretions. And thirdly, by acting on the beta-2 receptors of the mast cell, it inhibits the release of mediators from the mast cell and helps to inhibit inflammation in bronchial asthma. The third therapeutic use is cardiac resuscitation. Intracardiac administration of adrenaline reverses the cardiac arrest. This is because adrenaline acts as a cardiac stimulant. The next use, adrenaline can be combined with local anesthetic drug to prolong the duration of local anesthetic effect. Adrenaline, by acting as a vasoconstrictor by stimulating the alpha-1 receptors of the blood vessels of the skin and mucosa, it delays the absorption of drug into the systemic circulation, thus prolonging the duration of local anesthetic drug. Secondly, because of the vasoconstrictor action, it reduces bleeding. Thirdly, because of reduced absorption of the local anesthetic drug into the systemic circulation, the systemic toxicity is less. So this results in enhanced local anesthetic effect and reduced toxicity. Lastly, adrenaline can be used for the treatment of epistaxis, that is, it reduces bleeding because of vasoconstrictor action through alpha-1 receptor stimulation. Next, we move on to the adverse effects of epinephrine. Firstly, epinephrine can increase the blood pressure and can lead to cerebral hemorrhage. Secondly, it acts as a cardiac stimulant. By stimulating the cardiac contractility, it increases the workload of the heart and can precipitate the onset of angina and arrhythmias. Thirdly, it can also cause CNS side effects such as headache, generalized restlessness and apprehension. So what are the contraindications of epinephrine? 1. Epinephrine is contraindicated in hyperthyroidism. In hyperthyroid individual, there is upregulation of adrenergic receptors and this increases the sensitivity of the myocardium to catecholamines. So this increases the chances of angina and arrhythmias. Second, epinephrine is contraindicated in a hypertensive patient as it can increase the blood pressure and can lead to hypertensive crisis. Epinephrine can precipitate the onset of angina and can trigger the onset of arrhythmias as it acts as a cardiac stimulant and increases the workload on the heart. Lastly, it can also lead to drug interactions with drugs that enhance the availability of epinephrine. For example, tricyclic antidepressants by inhibiting the reuptake of epinephrine into the nerve terminals increase the availability of epinephrine in the synaptic cleft. MAO inhibitors inhibit the metabolism of epinephrine, thereby increasing the availability of epinephrine, leading to side effects. Halothane increases the sensitivity of myocardium to catecholamines and increase the chances of arrhythmias.
These are my references. Thanks for watching. Please like, subscribe and share.